All right, good afternoon. I'd like to welcome everyone here in the room back for this afternoon session, our last session of this year's Sentinel update meeting. And as you heard this morning, there are a lot of new developments within the Sentinel program as it's now graduated from Mini-Sentinel, and as you heard from FDA, is an integral part, a transformative part of its post-market evidence and surveillance activities. What we're going to focus on this afternoon is some of the ways to expand the Sentinel infrastructure, some of the opportunities for expanding it beyond safety surveillance. So you heard Janet Woodcock in her opening comments talk about this capacity for bringing data together while keeping it apart, bringing the information together while keeping the data apart in this distributed framework, and how it's been built out over these past few years to having a much more significant capacity for learning from real-world data on a potentially very large scale, but with some limitations as well. So this afternoon we're going to focus on some of the best opportunities or some of the potential opportunities for expanding this kind of infrastructure to new uses. And I thank all of you who are here with us in the room today, as well as all of you who are joining us on our webcast right now. We're going to have a range of panelists talk about potential expansions of Sentinel use and how it might fit in with other activities in these areas related to better evidence from actual practice in our healthcare system. These include areas like the potential for Sentinel to support better information on quality of care and utilization of care, the role of Sentinel in supporting public health surveillance activities, and the role of Sentinel to facilitate the conduct of clinical trials and maybe help guide some pre-market activities, among other topics. And all these were touched on this morning, but we're going to spend more time on them this afternoon. So we have a range of perspectives from experts who have been thinking and working in all of these areas with us on the panel this afternoon. We're going to hear first from Marcus Wilson, the president of Health Corps at Anthem. I got that right? And he's going to talk about a wide range of activities that Health Corps has been working on since its interests touch in all of these topics, and how Sentinel might be a bigger part of that in the future. Rachel Florence, you all heard about the important work that the Patient-Centered Outcomes Research Institute is doing earlier today, including the connections between PCOR Net, the Outcomes Research Network that PCOR is sponsoring, and Sentinel and Sentinel-related activities already. Rachel's the program director for comparative effectiveness research methods and infrastructure at PCOR, and will provide a perspective from them about the best ways to improve the evidence related to comparative effectiveness. Dave Whedon, a longtime colleague of mine who is now Senior Vice President and Head of Global Regulatory Affairs for Patient Safety and Quality Assurance at AstraZeneca Pharmaceuticals. We'll talk about some of their experiences, including a lot of activities already in post-market surveillance and monitoring, as well as obviously the development of new medical products. Claudia Velosi is the chief of the prevention branch and the Division of Viral Hepatitis at the National Center for HIV/AIDS, Viral Hepatitis, STDs, and TB Prevention at the Centers for Disease Control and Prevention, and has been involved for a number of years in activities to do surveillance, including, I think, some connections even with Sentinel investigators, maybe more coming. And Dr. Chris Castle is the president and CEO of the National Quality Forum, which is the multi-stakeholder entity that has responsibility for endorsing and promoting the use of effective and consistent quality measures to improve care in the United States, and has a tremendous amount of experience with large data efforts from diverse sources to try to fulfill that goal. So we're going to start out with some comments from each of these panelists, and then we'll have some time for discussion in the latter part of this session. And Marcus, I'll turn to you to begin.
Great. Thanks, Mark. So I was just at a conference this week in Orlando, and one of the things that one of the speakers, and I thought he was a terrific speaker, one of the first things he did in his presentation was he showed a film clip of the first time that Steve Jobs ever talked about the electronic data, the iPod specifically, and getting into the music side of the business. And what was interesting about this, and the reason he showed this clip, was that he said that the most important thing that they did when they launched that technology, and which is now what we can consider probably one of the most transformative technologies of our generation, was that they talked about, instead of talking about what, they talked about why. If you look at it, if you ever get a chance, go back and look at this. And he talked about why they're doing this. And that's what they focused on. He never even mentioned the iPod in the first presentation. And so I thought it was a good way to kind of start this conversation a little bit about why. And not only why we started all of this, but why even an organization like ours, Health Corps and Anthem, were involved in this. And it really stems from a realization that many of us had early in our careers. I'm a clinical pharmacist by training, and early on in my career, I spent 7 years inside of a group practice, and I really learned early on about where some of the biggest challenges we have in healthcare exists. And Rob Califf and his team, they did a study back, I think it was 2009. It was published in JAMA. And I've used that now in a lot of my messaging as I've talked about the why on all this, because I think it really underscored one of the most critical issues we're facing in healthcare. And what they did was they went back in and looked at all the cardiovascular treatment guidelines. Now, for health plans and for providers to a certain extent, the treatment guidelines are the holy grail, right? And that's what we use to frame out decisions. It's what we use for quality assessment when we're comparing against providers or ourselves against what is done versus what should be done. But what they did with that, and looking at the cardiovascular guidelines, is they looked at all of them that grade their evidence, and then they looked at the 16 guidelines that were the current guidelines or versions of those guidelines. And within those 16 guidelines, there's 2,700 recommendations. Within those 2,700 recommendations, remember, guidelines are like treatment algorithms, or they're decision trees to a certain extent. And so you look at each one of those 2,700 recommendations, and then you look at the level of evidence that goes in each one of them. And what they showed is that there was only 11% of those recommendations was there sufficient evidence to support it, which means that the majority of the evidence or recommendations were based upon, one, a single trial, or more often the expert opinion. And so those of us who work on a large national scale, and as most of the folks on the panel up here, realize that the problem with expert opinion is every expert has a different opinion. And it's not wrong. You're in clinical practice and you're working and you've developed your experience, and so you have your own expertise and opinions, and it may be very different based upon a lot of different factors for someone else. And so guidelines are inherently flawed, and they're flawed by the fact that by the underlying issue that we have. And by the way, the issue is the same for oncology, which is about 6% in oncology, and even for infectious disease, which it's maybe, depending on what part of infectious disease you're looking at, is less. It's always less than 20%, and most of the time less than 10% of the case. So we're working on treating our patients that on data, on information that is often lacking. And that's when I was in practice, was one of the things that just scared me a lot in practice, is realizing, coming out of training and into practice, just how much we don't know. So in thinking about evidence development, evidence generation, that's where we start thinking about, we have to have an infrastructure that will improve the speed of how we generate evidence. So we started out in Sentinel 7 years ago. And really, the motivating factor really could be pointed to is actually speed. So if you think about something like Vioxx as an example, which is often used as a poster child, the problem with Vioxx is that it was on the market for 5 years before we reached a threshold of saying it shouldn't be on the market. I want to go back to, and Merle made a great point this morning, and that is it's not just about speed, it's also by precision. Because the reality is that Vioxx probably should have been on the market, but only for certain people. What we think probably was, we can't assess quite yet, is that there's subpopulations where the risk was overwhelming. And that was the groups that really need to be steered away from it. So again, pointing to the flaw, not just about speed and generalizability, but also being able to get to individualized therapy and manage populations very effectively. So I think for us, in thinking about how we extend beyond just safety, obviously clinical, humanistic, and economic outcomes are critical. We talked about the balance of evidence needed to make sure that we're making good, well-informed decisions in healthcare. And as we look to expand beyond the use of Sentinel and this infrastructure for safety, thinking about it, making sure we're careful and thoughtful in how we do that, what types of data we begin to add together, which we clearly have to do. Administrative data, as was stated earlier, is critical as a starting point, but certainly not the end point in how we actually build that view of those populations and generate that evidence. But as we do that, evolving the methods, the technological process, as well as the business considerations are all that are really critical. So I'm looking forward to hearing more from the panel and questions from you.
Marcus, thanks for those opening comments. A great way to frame this discussion. So I'll turn next to Rachel, and I think you can hopefully just click ahead there. Yeah.
Thanks. Good afternoon, everyone. So I'm delighted to be here to talk about pCoreNet and our links with Mini-Sentinel. So I hear that Rich spoke a little bit about pCoreNet this morning, so I hope I'm not repeating too much. But essentially, the vision for pCoreNet is to be able to create an infrastructure that will improve the efficiency of clinical research in our country. And we launched last January in 2014, and we have five main aims in our first phase of our project. One is to engage with patients, clinicians, and health system leaders, as well as researchers and other partners in this enterprise. The second is to build a collaborative community that's willing to think about this resource as really as a national utility, as opposed to sort of a loose federation of research networks. The third is to have analysis-ready standardized data, and that's probably what Rich spoke to you a lot about this morning, so this ability to use the common data model to query data in a really rapid fashion. Fourth, of course, the other side of that is the oversight and the protection of patient privacy. And then finally, we're looking at really research integrated into the delivery of care and thinking about the ability to run trials integrated into the delivery system in a way that's much more seamless than we've been able to do so far. So these are sort of our five aspirational aims for the first phase of this project. pCoreNet is a $100 million investment from PCORI. We've invested in 11 large clinical data research networks. These are largely health systems and healthcare delivery systems that have come together. And 18 patient-powered research networks that are engage patients who are willing to participate in research, ask questions, collaborate with researchers in order to get their questions answered. And then we have a coordinating center led out of Harvard Pilgrim Healthcare that Rich Platt co-leads or co-led with Rob Califf until very recently. So we're a year into this effort, and so there's been a lot of work involved in just sort of getting us off the ground, but a few things I think that we're starting to see emerge. So we're a network primarily based on EHR data, and the link with the claims data is really critical to the rigor of the research that we're able to conduct. So while we do have access to this wealth of EHR data, a lot of the work involved is in linking it with claims and being able to really answer robust questions. We support both observational and randomized clinical trials. We're about to launch our first trial within pCoreNet. It's comparing two different dosages of aspirin in patients who've already undergone a coronary event. And the other thing I think that's novel and coming to view with our network is just this real engagement that PCORI has sort of shepherded and championed, but we are building this network in collaboration with patient communities, with clinicians on the ground, and with health system leaders. So I mentioned the aspirin trial. We're also about to launch two large studies in the area of obesity. Rich and the Mini-Sentinel folks are Rich Platt, for the folks on the webinar, and the Mini-Sentinel team are sort of really helping work on the common data model in order to be able to run these studies in in a way that's faster and cheaper than we've been able to do until now. And then we're also thinking about a third set of studies, which we're calling for now rapid cycle research, which is asking health system leaders the questions that matter to them and being able to try and leverage the infrastructure to do this kind of research as well. This is our timeline. I won't go over this a lot, but we really are only sort of a year into this. Our first phase ends in the summer, and then we're launching a 3-year phase 2. So overall, it will be a 5-year program. Just wanted to mention a few words. I suspect that you probably saw versions of these slides this morning, but PCORnet is really, I want to make sure that I put it in the big picture of the other national the national sort of efforts and initiatives that are going on in the country. So Mini-Sentinel is definitely one. The CTSA is run by NIH on the other hand, and PCORnet there in the middle. And we're really trying to sort of leverage all the different investments so that we're working in a seamless way. Another slide that you probably saw, this is another slide from Rich Platt and his colleagues, really showing you sort of the function of our coordinating center, which will receive queries and respond to queries using our analysis-ready data sets. This is our common data model. It's similar to the Mini-Sentinel common data model, although not exactly the same. And a lot of our work, as I mentioned, we're in EHR, largely EHR-driven at the moment. A lot of our work is in adapting and working on the common data model and leveraging the EHR information. So many initiatives that should share resources. So the links between Mini-Sentinel and PCORnet, I think, are strong and exciting in terms of what we can do in the future. So helping with the data structure, the way the quality assessments and the program libraries can be developed. PCORnet has a lot of emphasis on really trying to streamline the sort of the machine involved in research, so the IRBs, the contracting. So we're really sort of working with our networks to streamline these processes, investigating ways to do centralized consent and follow-up functions as well. Okay. I thought I'd say a few things about the touch points between Sentinel and PCORnet. I hope you haven't heard of all of them, but there's certainly important opportunities to leverage the Sentinel investment and infrastructure with the PCORnet infrastructure. The coordinating center, of course, is shared, and so the work that they're doing on Sentinel is leverageable for PCORnet and vice versa. I hope there are a lot of learnings within PCORnet that will be helpful for Sentinel. 11 of our PCORnet CDRNs have accepted to participate in Sentinel, so they will be participating in, I think, ways yet to be defined. And then again, the coordinating center is helping discussions between the Sentinel partners and our CDRNs and PPRNs in order to really help leverage the data relationships. And that's the end of my presentation. Thank you.
Rachel, thank you very much. I'll turn next to Dave.
Good afternoon, and as usual, thank you for coming back. Good afternoon, and as usual, thank you for coming back from lunch. Happy to see such a large turnout. I'm going to talk a bit about sort of broader uses of Sentinel, the infrastructure upon which Sentinel is based, moving beyond the safety aspects that we heard so much about this morning. At AstraZeneca, we have focused on a number of areas in which large patient-centered databases would be very useful in terms of how we develop or further flesh out the promise of products, such as cardiovascular disease, in particular thromboembolic events associated with cardiovascular intervention, metabolic diseases such as type 2 diabetes, or in the case of a smaller patient set, but an importantly needful patient set, immuno-oncology, where genetic variants could have a huge difference in terms of outcome. So what are the sort of potential larger roles for Sentinel or Sentinel-like associated databases that could greatly enhance our ability to develop innovative therapies? Well, some examples are the following. The use of such databases to further flesh out descriptive statistics on diseases, or compounds, not products, but compounds with similar mechanisms of action, and natural history of disease. It could certainly help to be more refined in how we decide to study innovative therapies in certain patient populations. We've already heard a lot about comparative effectiveness studies. Certainly this continues to be important, and not just product against product, but mechanism of action against mechanisms of action would be an important area for further research. Trial feasibility and trial design. Many companies are embarking upon innovative approaches in using therapies in addressing unmet medical needs. But because it's so innovative, many times we're not sure about the type of trial, the shape of the trial, the design of the trial. So such large outcome-based databases could be useful in helping to refine the feasibility of trial designs, the endpoint assessments, and the effect size that one might expect in approaching these innovative approaches. Additional areas of useful deliberation and research could be looking at unapproved indications. We all know that many physicians take medications and use them in ways that are not delineated in the prescribing information. It might be useful to have a better understanding in a large descriptive database such as Sentinel should and could have, in understanding how these unapproved indications either mimic or related to the indications for which a product or set of products may already be approved. Pharmacoeconomic uses. I've in the past had health economics and outcomes research as part of my remit, and it's extraordinarily difficult to get good, robust pharmacoeconomic data, preferably during the course of drug development and not as a part of post-marketing assessment. So such databases as Sentinel or Sentinel Plus could be informative in that domain as well. And lastly, but certainly not least, patient-level outcome prediction. We all know that different patients will have different sets of outcomes, regardless of the similarity of the modality of therapeutic intervention they may be undergoing. So the more we can delineate those patients that will have preferred and enhanced outcome, and by association, diminished associated risk, the better able we are in terms of refining who we choose to recruit into clinical trials for further delineation of promise and effectiveness. So I would very much challenge one statement I heard earlier today, and that is that Sentinel is solely for safety, and would very much echo another statement I heard earlier today, and that is we really need to have databases that adequately and robustly and holistically address not just risk, but the combined parameters of benefit and risk. And certainly Sentinel and the infrastructure that's supportive of Sentinel could be very informative as we go down the road of having that combined, balanced look at benefit and risk, so we can, at the end of the day, better serve the needs of patients and better serve the needs of unmet medical needs. Thank you.
Dave, thank you very much. And I'll turn next to Claudia. I think you have some slides.
Yes. Good afternoon. I've been really learned a lot today, have a better understanding of the potential of Sentinel and how it might be able to fill some of the gaps in our public health needs, but specifically to hepatitis C infection. And I'm going to give you just a brief background on that in a minute. Hepatitis C infection is actually probably a pretty good public health issue to possibly test a system like Sentinel for public health surveillance, because it really represents acute infections or incidents, and where we have to break transmission modes. And then it's also a chronic disease, and there's a number of steps of preventing the secondary prevention, basically preventing morbidity and mortality from the chronic infection. So let's see. So just briefly, this is a slide just showing you the incidence. Rates of acute hepatitis C have been decreasing since the 80s. They've kind of stabilized until recently in about 2010, we started seeing an uptick in incidence of hepatitis C. And it's largely been driven by intravenous drug users, young, white, and primarily rural populations. The map shows you that there's geographic variations, but however, some states have experienced greater than a 200% increase in incidence. So let's talk about chronic hepatitis C infection in the U.S. The U.S. has a large burden of hepatitis C. There are 3.2 million Americans living with hepatitis C infection, and about 3 out of 4, 75% of these Americans are born between 1945 and 1965, and we'll refer to them as the baby boomer cohort. Hepatitis C chronic infection is the leading cause of chronic liver disease and hepatocellular carcinoma. Deaths from chronic HCV infection are increasing, and they now exceed deaths due to HIV infection. But there's an important development in recent availability of direct acting antivirals. They're easier to take, they're all oral, there are fewer side effects, shorter treatment duration, and they're much more effective with greater than 90% cure rates, which is really, I'm sure you've heard it on the news. It's really transformed this whole picture. So in 2012 and 13, the CDC, as well as the U.S. Preventive Services Task Force, came out with recommendations for one-time screening for persons born between 1945 and 1965. Again, they make up 3/4 of the prevalent HCV infections. The recommendations were really driven by studies that showed the risk-based testing had limited success because about 50% of people living with HCV don't know they're living with HCV. So we need to improve that. We need to identify these folks. And then again, the data has shown that the baby boomer cohort is responsible for 3 out of 4 of these prevalent cases. So in addition to the one-time testing, we of course need to test persons at risk for infection that need to be screened and tested. So we're at a point now where we need to assess the uptake and measure the impact of these recommendations. Oops. Let's see. So I'm going to focus on chronic HCV infection. Several studies have looked at gaps in the care cascade for HCV. There's small differences, but basically all the indicators for testing and care are similar at each step of the way. So for us at CDC, monitoring these data are key to monitoring the uptake of our recommendations and the outcome of the recommendation. That is, people getting into care and people reaching a cure. And this also will help us direct our prevention efforts and to prevent morbidity and mortality. So if you look at the bar on the left represents 3.2 million people living with HCV. The next bar represents the 50% who are aware that they have HCV. So that means there's about 50% who are unaware. So we took a big step down right there. And then getting people into care, which also is including an RNA confirmatory test after somebody gets a screening test for the antibody. And on down the road, did they start treatment and did they reach cure? So in the context of this care cascade, with some help from my friends, I put a table together to kind of look at the public health questions we have at each step of this care cascade, and what the measure would be, of course, and then what data elements are required, and that's what we're after, is where we can get these data elements so we can monitor this cascade and make sure people are getting the care and treatment they need. So the first one, of course, is what are the trends in HCV testing among the target populations. This is a proportion of those tested. We need a simple HCV antibody test for that, to monitor that. Another core question would be how many people have been diagnosed and are aware. Again, this would require that HCV RNA test because that means they were confirmed positive and infected. Again, and then another question, core question would be those who were diagnosed, how many of those folks got into care? What proportion of infected persons are receiving care? And here we broaden out our data element needs. I mean, one thing we can look at in the claims data or the medical record would be, did they get referred to subspecialty care from either a primary care site or a community clinic or whatever. But other elements, and these elements in the far right column are common to basically all the rest of our questions. So they're laboratory elements. An HCV genotype would suggest that these folks are in care. Liver enzymes and platelets, not only would that suggest they're in care, that is also necessary to assess prior to treatment. Did they get a liver imaging test, such as a CT, MRI, or a FibroScan? We can always look at diagnostic codes for HCV, plus or minus liver cirrhosis or fibrosis. And then, of course, we'd want subpopulation characteristics to determine if there's disparities or where the liver stage might be when they initiate a treatment, and then the outcome in terms of cure. So all of those elements would probably be important, again, for all of the other questions I have over in the far left column. We want to know how many people initiated treatment, and we want to know by which genotype, at what liver stage, et cetera. One additional data element, of course, would be prescriptions filled. I think that would be available in Sentinel. How many people with HCV infection were cured? And by subpopulation, by genotype, by stage of liver disease. Again, we'd need all those elements in the far right column, but we would also need the RNA laboratory data at very specific times. Before treatment started, a couple weeks into treatment, is it working? And then, of course, end of treatment, did they have viral suppression? And then 12 weeks post end of treatment, which would show sustained virologic response, which implies cure. So those are all the steps. Those are some of the core questions. There's many more. There's also many more things that I thought of that we could possibly look at if we had a longitudinal data set such as Sentinel. The first one I already talked about, again, is that care cascade, but one of the important things for us is to identify what are the barriers to making it to the next step, and are there disparities in access, and what are predictors of underperformance. We could also be looking at access to liver disease following a SVR. How many regress? Does the liver stage regress? Does it progress? We can only really do this with a longitudinal prospective data set. We could assess other comorbidities that are potentially associated with chronic hepatitis C infection. Some of those things that have been very hard to really show a demonstrable association, such as depression, chronic fatigue, fibromyalgia. A lot of these things people say once they're treated, they realize they feel so much better, and they didn't even know that they were feeling these things. I thought that we could almost do a self-controlled analysis with the Sentinel, looking at pre and post treatment. Of course, adverse events following the direct-acting antivirals, and access to reinfection. We want to assess relapse and reinfection. It's pretty critical because once you are cured, if you still continue to have high-risk behaviors, you may be reinfected. So those are just a few additional examples that I came up with, aside from the core elements that we would need. Let's see.
Claudia, thank you very much, and on down to Chris.
Thank you, Mark, and I want to thank you and Brookings for inviting me and including the National Quality Forum in your thinking, which I can tell from being here today. Thinking about Sentinel and its future is becoming much more expansive, and I congratulate you on that. So what I want to do is kind of take us to not away from looking just at pharmaceutical and device impact, as important as that is, but if you can imagine sort of stepping back in the healthcare system and looking at the whole story about quality of care for our healthcare system. And from where I sit in trying to set standards with a whole range of stakeholders from throughout both the public sector and the private sector in healthcare, for how we measure and describe quality of care in ways that are fair and rigorous, but also understandable to consumers and meaningful to providers so that they know what to do in order to try to improve. That's the challenge. And it really is, when you think about the challenge of information about clinical quality and safety, it has to be both personalized and based on populations. And in order to do both of those things, the answer, I think, in 2 words, is big data. And that's real. It's funny, we haven't been using that language very much today, but that is really what we're talking about here, and the future of the ways in which, I loved Rich Platt's term, hypothesis-free surveillance, because as many of us who came up in the world of very rigorous approaches to research, answering questions, we, number one, don't have the luxury for the time and cost that it takes to answer questions one at a time in that way. And number two, there really, I think, are beginning to be very clear indications that we can use a messier approach. We can ask ourselves how close is close enough and get very, very useful information much more quickly. So in the world of quality metrics and looking at measurement systems for quality of care, there's 2 really important constraints, and one of them is the sources of data. So that's really part of what we're here talking about today. But also this phrase, analysis-ready data, and the ability to do the analytics that are needed is an important part of this. So I want to switch gears just for a couple of minutes and tell you about another hat I wear, which is as a member of the President's Council of Advisors on Science and Technology, 20 scientists covering a wide range of science and engineering who are independent advisors to the President Obama. And as a member of that group, I had the opportunity to chair a study that was released about 6 months ago called Systems Engineering in Healthcare. And if you're interested in seeing the whole report, it's on the PCAST website at ostp.gov. You can Google it and it'll pop right up. What this study was about, the fact that really high-performing health systems have adopted engineering approaches from other industries to reduce waste and improve reliability, 2 things that any industry wants to do, and that healthcare is very bad at. And so that there's been really good successes, but the practices haven't spread widely. And so the administration asked us to get a group of engineers and healthcare experts together and make some recommendations about how we might accelerate the spread of those kinds of practices. And so there were a whole range of recommendations. I'm not going to go over all of them, but if you're interested, I saw some people nodding, so maybe there's some people with engineering backgrounds here. I'm giving a talk to the College of Deans of Engineering Schools next week, so I'm having some kind of interesting conversations about it these days. But the key thing, our second and third recommendation, was that you got to have the data. If you're going to do, any engineer will tell you, you have to have real-time, reliable data that you can trust, plus you have to be able to do the analytics so that you can turn it into information. And so we make a set of recommendations about what the federal government could do to help the healthcare system in all of its variability and regional variation, et cetera, be able to have access to more information. And one of the things we observed is that the federal government itself has huge amounts of data, and this is where Sentinel comes in. FDA, for sure, has really advanced the ability to look for signals in ways that actually could help improve clinical quality and safety. But we heard this morning about potential connections with VA and the Department of Defense and all of CMS, not just Medicare and Medicaid, but a whole range of other approaches to data. And as a matter of fact, just recently, Niall Brennan was made a data czar. I don't know what his exactly official title is, but promoted to a kind of a cross-CMS look at how can we really bring many of these data silos, even within the federal government, together. Our recommendation was that we also bring the private sector to that table and begin talking about healthcare delivery systems. There is now a whole organization of the platforms that you heard some of. I think all of them are probably, Rachel, involved in PCORNet, but that are developing consistent data platforms for all of the clinical data that comes out of their electronic health records that then could potentially be mined and shared for these kinds of information, the kind of information you've all been talking about today, but also information that the clinicians need for improvement and that the payers need to know what they're buying in healthcare. So I'm mindful of the point Marcus made, taking from Steve Jobs, that we need to talk about the why. Why, I mean, if you're a data geek, all of this is really wonderful, but a lot of people might be saying, well, what do we really need this for? Well, the cost of healthcare and getting more value for our dollar strikes me as a really urgent need. And as a matter of fact, just less than 2 weeks ago, Secretary Burwell made an announcement that CMS is going to dramatically accelerate the use of new alternative payment models within Medicare, and all of those payment models depend on something that's called value-based purchasing. And the first thing she said was, that means we have to better define value. So, and I happened to be there at that announcement. She looked right at me. And so we as a nation really need a better, quicker, more systematic way of developing measures of quality that are meaningful. And that can be done with the combination of all these data systems. I want to publicly thank Mark and Brookings for another initiative bringing healthcare quality people together to talk about how systems of data could be used so that the collection and reporting of the data is not yet another burden and another cost on our healthcare system, which unfortunately is too often the case now. So I think we're very much in a transition phase, but very committed to and excited about working with you as we make this transition to having data be both more reliable and also easier to access and having greater scope. So thank you. Mark, I'll turn this over to you.
Chris, thank you very much for the comments, and I'd like to thank the whole panel for the diversity of applications for information that comes out of data. I like the data versus information distinction that was made this morning, and how, as you look across many of these different applications, there clearly is a lot of overlap, not only in data sources and organizations that need to contribute, but in developing common data models, tools. Rachel was talking about the registry of tools that you all are putting together that builds a lot on Sentinel efforts. Chris just talked about getting to meaningful improvements in value or outcomes, which in turn depends on clinicians and patients having a clear knowledge about what they can do based on these underlying data and information to get better results. So it all seems like it overlaps, and it seems like we're really making progress towards what people have called a learning healthcare system. But it does require, as Sentinel has shown, getting down into the nitty-gritty, or as Joe Drozda called it, the swamps of trying to get useful information out of these complex systems, and doing it in a way that brings along all the stakeholders, the data owners, the patients, the regulatory agencies, the payers, and of course the providers to support the efforts. So I've seen a lot of different perspectives on this. We'd now like to turn to you all for any thoughts about potential further opportunities for the Sentinel Initiative to support this broader movement towards turning data into information and evidence for improvements in care. If you have any questions or comments about the topics we've talked about today, please head up to the microphone. While we're waiting for that, I did want to raise a couple of issues for follow-up that we heard about in the discussions today. I think Dave and others gave a good list of many of these potential applications of what's been learned in Sentinel. But there are some differences from Sentinel that I wanted to highlight, and for those of you on the panel who have experience with these issues, to see if there's some further comments that you could make. One of the key factors with Sentinel is that it is a public health authority activity. The FDA has authority, and there's a clear public interest in learning more about the safety of medical products that are on the market. And that's different from the typical authorities for the conduct of clinical research. As you move from questions about safety surveillance to questions about comparative effectiveness or other things that are more in the research realm, as Rachel noted, issues like IRB approval and processes for informed consent are important. It's not that patient information and engagement or marriage is unimportant for Sentinel as well, as we heard this morning, but it is a different set of regulatory issues and institutions and structures. And I wonder if any of you all, based on your experience in with both Sentinel type activities and beyond that, could comment on how you can get for a large scale effort like this one, a kind of feasible approach to IRBs and consent. So this is much larger scale than a traditional clinical trial done at one or a few institutions. And Rachel, you've had a lot of experience with these issues. I appreciate your further thoughts on this and maybe where PCORI thinks things should go, and if there are other members of the panel as well, for how Sentinel, the Sentinel Initiative might better incorporate patient engagement and consent and IRB type issues.
That's a big question.
Yeah.
But thank you for asking it, because I think it's definitely true that in clinical research we're under a different set of rules and regulations. I'd say that in PCORnet we've made a big push to ask our systems to streamline their IRB approvals within their sort of their own network. So we're incentivizing the systems to really sort of either seed their IRBs or share their IRBs or have a centralized IRB. Centralized IRB isn't necessarily the best solution or the optimal solution. It really depends on the question and what's at hand. But there are ways in which funders or federal organizations can really sort of push the envelope in this area. I mentioned a few words about our first trial that we're running, which is the comparison of different dosages of aspirin. And we're really implementing novel ways to identify patients, then get approval to be able to contact them, and then they'll be doing an electronic consent through the internet. So we're really trying to take the burden away from the clinician while still keeping the clinician engaged and keeping the patient-clinician relationship there, but sort of without burdening either the patient or the clinician in that way. So I'd say that sort of the use of the electronic health record, the advances in technology are really sort of helping us now implement research and practice in a way that's much more nimble than has been possible to date. Last thing I'll add though is that we also understand that there are populations that do not have access to internet, so we're reserving a part of this trial for the old-fashioned paper and pencil, so that we're not forgetting these populations and their important participation in this kind of research.
Rachel, any results yet on or thoughts yet about how patients will view that electronic consent process? I mean, it is different than the old paper and pencil, but it does seem like, just like the web generally lets you, in principle, lets you click to what you really want to know. It seems like there might be some advantages there.
So we hope. Well, we don't know yet. We hope it will. We hope it will be game-changing, and we're also, as I say, the involvement of the continued involvement of the clinician, but not in a way that's burdensome to them in their workflow, I think is going to be important as well. So we'll report back next year on the progress.
Other thoughts from the panel on this issue?
Certainly, I would think as well, it depends on the level of granularity you're going to, Mark. So I think as we heard this morning, Sentinel and the infrastructures that support Sentinel, and I know at OMOP as well, you wanted to have a reasonable set of de-identified data such that patient confidentiality and privacy is not encumbered. So a lot of the things I was talking about, for example, would be more population-based sort of approaches where the privacy issue should not be as paramount because you really can't drill down to the individual patient identification sort of parameters.
Thank you.
Yeah,
Marcus?
I mean, David's right, to the extent to which your design, your research design doesn't require you to get to PHI. So in other words, you have existing data that you're going to be querying, or where you need to get to the individual patient, or you're not doing a prospective type study, then it certainly is well within the privacy guidelines to be able to do the types of data. And I think I do that types of research, and I don't think that's the real big issue. I think when Rachel's looking at something like aspirin, you actually have to go to different sources that are not contained within the current databases, at least on a regular basis today, or a uniform basis, and that's when you need to typically reach out and touch the member. And those of us who've done that type of research for a while know that that process is doable, but it is cumbersome, it's time consuming, and a little bit more expensive as you have to do that. So I like the idea of being able to get to the get to them through the internet, and I hope to learn more about how you guys are succeeding in that or not.
Great. Also, as you point out, and this gets to my next question, is actually I'll go to your question if you want to go ahead, and just please tell us who you are before you ask. And I'm going to, if there is time, I'm going to come back to the difference between some other differences in methods and the like between the prospective randomized studies and the retrospective or other observational studies. Picking up on Marcus's point, please go ahead.
Thanks, Mark. Kevin Haynes with HealthCore. So I want to pick up on extending the why into the how. And it really has a lot to do with, we'll take a hepatitis C example of, let's say, a pediatric hepatitis C patient who lives in Lexington, Missouri, where there's an HCA hospital. So they're seen at an HCA hospital. Maybe they're an Anthem member as well. So now they're in both of those data networks. And then maybe they go on to get care at, say, the Greater Plains Collaborative Group within PCORnet. So you really, and then, maybe then they get to a point where they go into Medicare for whatever reason, maybe they have chronic kidney disease or whatnot. And now you have this fragmentation from a longitudinal perspective across different data partners. And then you also have clinical depth issues with regards to HCA and various PCORnet. And so this gets at a lot of the issues that you raised of the needs with regards to those laboratory values, which may be in some systems and may not be in other systems. And of course, if you have consent, and how do you propose doing some of these further linkages? I obviously have some idea.
Mark, can I actually?
Please go ahead, and then we'll see how the rest of the panel does, and then maybe you can come back to your ideas too.
I'm not going to answer this. I'm going to add to your wonderful question and make it even more complicated, which is, so the patients who have hepatitis C want to know where do they get the best quality of care, and the payers want to know, which doctors should they be incenting or signaling that they need to figure out how to do better. What data do they use? Which system is responsible for the patient in the scenario you just described? So, that question is also very relevant to the accountability framework that I was talking about.
Yeah, it's not just about the drug. Comments?
I think we need to call Kevin back up to answer the question.
Answer your own question if you want. Yeah, he's got it.
So the solution, and we saw the sort of the what makes distributed data work earlier, the slide with the firewalls. And what's going to happen is some of those firewalls are going to have to break down in cohort-specific studies so that whether a study idea originates on a PCORnet side or an NIH collaboratory side or a Mini-Sentinel side, that there are then ways and mechanisms around the linkages that need to get done to do those things. So the future may change that slide with those firewalls, with regards to building out the governance that needs to get put in. And Sentinel spent a lot of time in the governance of what is in existence. We're going to spend another 5 years working on the governance of how we're able to link these data together to maximize the efficiencies. With HCA now on board, that's the first opportunity where you could be in more than one place at one time.
Great.
Mark,
Great answer. And if you want to go ahead.
if I could add a comment to that. If any of you, I'm sure everyone in the room has gone through this, if you've ever gone to check your credit rating, it's amazing how those databases, as disparate as they may be, communicate with one another because of a common identifier, your social security number. So those databases know exactly where you live, for how long, what your phone number was, what car you own, all those things. So we have examples where the firewalls and the bricks and mortar break down and these databases communicate with one another. There's no reason why it can't happen in the healthcare scenario. We aren't thinking creatively enough.
Marcus?
In California, one of the things we're doing is we just announced an initiative last fall called CalIndex, which is a California Integrated Data Exchange, is what it stands for. So there's two of the larger payers, our Anthem subsidiary in California, which is Anthem Blue Cross, and then the separate entity, which is not owned by us, it's Blue Shield, announced that we're going to jointly stand up this CalIndex. And the idea behind CalIndex is to actually begin to get to some of the issues that Kevin outlined on this, and that is, one, we're putting all of the payer data into this in a longitudinal fashion so that we're, as individuals begin to move between different payers over time, we'll be able to follow them and get that history as a natural course of that. In addition, there are 32 of the largest health systems in this, so the provider groups on this side are actually coming into that initiative as well with the same intent, not only to integrate our claims data with their clinical data, but also to begin to give that longitudinal view to begin to solve some of those issues. So it eventually will get to a lot of those things, and any of you who have actually been involved in these know how complicated all of that is. So we're starting small and trying to build it out with sort of the high priority items first. Hep C would certainly be one of those, but I think that as we look to sort of enable this capability, we're thinking about it broadly, not just safety, but safety included, but other types of issues around being able to look at other types of outcomes as well. So I think it's complicated, it's hard to do, but it's going to take efforts, grassroots efforts like that to really make something like that work.
And for doing these additional data linkages, it is important to bring the patients along and have opportunities for education, building off the kinds of tools and approaches that Rachel described and what we've heard about this morning. And also to go back to your original point, sort of the jobs point, it's not just the what, it's the why. And you said you're starting with some high priority issues, and I assume that some of those high priority reasons why to do this focus on improving patient care, something that really benefits those patients directly.
Absolutely. No
Yeah.
question.
And in the, there are some Sentinel experiences along these lines. I heard this morning about the linkage of the National Death Index data for finding patients who had cardiac deaths out of hospital, which is a real risk, a real concern around some drugs and some patient populations, but can't be done within the traditional Sentinel data structure, short of the perfect linkages that you all are aiming for. That was done with a probabilistic matching approach, as that may be a mechanism to help start getting down this road, and may also avoid the need for sort of full individual data linkages that might make some individuals nervous or something like that.
Sure.
Yeah. Okay. Next.
So, I mean,
and let us know who you are.
Oh yeah, sorry. This is Ben Haywood. I'm one of the founders of Patients Like Me. Hey, Mark. This has been great today. Thank you, guys. I think as we think about, enabling other actors other than the public health use of this data, I think we have to continue. I mean, Mark, you said bring the patients along. I actually think, as industry or other people, and we think about other uses of this data, ultimately we need to enable the patient in this data, not bring them along or David, I think what you mentioned about the credit bureaus, the reason those are all broken down is there's sunshine. Patients can go in, people can go in and say, wow, that's wrong, and then they need to fix that. When they fix it for one patient, they fix the system. And so we've done some projects with matching with large data brokers where we know the patients, so we can re-identify them back. And the reality is the data's wrong. And so if we enable individual patients in this data, they can correct it, they can fix it, they can make it right, they can add value to it. But I think we have to stop talking about bringing them along. Sharon mentioned it well with engagement or other things. That's not what this is about. It's about enabling them individually in this data and getting that in their hands so they can actually get this right. So I think we need to broaden our frame even bigger than we're talking about other uses, because I think we're still going to run into the wall with real problems that unless you really get patients in there, it's going to make a difference. So.
Great comment, Ben. Based on the work, before you go away, based on the work that you're doing, any thoughts about a good place to start, a good initial high priority use or case where this may be relatively
so the
easier to
challenges we
do?
have, with anonymous, with the hashing stuff, if you wanted to, you could opt patients in to engage and get that data back out. Now, in most of the data brokers, they have contracts that don't allow for that. I imagine even in the public health environment, you guys might have that. Well, but I'm wondering if there's a way from a regulatory standpoint or sort of a federal fiat we can trump that and enable because again, what we're talking about here, guys, is data on 170 million patients that they don't have access to. They don't know if it's right. They have data. You guys have data about people they don't have about themselves. And so what can we do from just a pure moral standpoint to enable them in that data? And so you can do this. If a patient opts in, you can anonymously match them out and you can pull that data back out. Now, again, on the industry side, that's contractually impossible. But from a public health standpoint, could we do it with some of these things? Be an interesting experiment. I'd love to help try and make that happen.
Any further comments? I see some nodding on the panel. Well, scary's okay. And when Sentinel started some years ago, all of this was purely hypothetical and wasn't clear that it could be done either. So I think this is the way to get the next frontiers for the Sentinel Initiative and more generally patient leadership and patient control in healthcare as part of the agenda. So thanks for the comment.
Mark, can I
please go ahead.
comment on that? Because the National Quality Forum has actually been in discussions with patients like me around the idea of getting more quickly to patient-reported outcomes measures, which is what the measurement world all wants, but it's too expensive, too difficult to get the data, all of those obvious reasons. Although why we can't just report it on our phones is beyond me in the year 2015. But
well, you're at NQF. You're supposed to.
Yeah, well, we're working on it. So I celebrate this idea, and I think that the idea of the federal lever is something I think it's worth exploring because, as you know, there is a sort of a current sense of liberating data. This administration and others are, very, at least intellectually in favor of that. Some of the data that they release isn't all that useful, it turns out, for all kinds of various reasons. But the fundamental concept, I think, is the right one, and connecting that to patients in a kind of Wikipedia kind of way to do corrections, I think is a very interesting idea.
Well, and the more these disparate sources do come together, the more useful that is going to be to individuals who want to understand their health and understand what they can do to improve it, not only to get the data right. I did want to go back to that one topic about observational studies, and so this is back from the future of patient control to closer to next steps where we are right now as we continue moving in that direction. We talk about a distinction between some of these uses for Sentinel that are we might call observational. So much of the safety surveillance that's done today is looking at patients who had different kinds of exposures to drugs or potentially vaccines, other medical products, and the outcomes that occurred. And we heard a lot about some of the methods development in that area. If you go down the list of uses of the data that you all have described, though, some of them go beyond that, getting into not just safety surveillance, but as Dave emphasized, for what patients and their physicians or clinicians are really interested in is not just the risk of a drug, but the benefits of a drug in that individual. That gets a lot closer to the kinds of things that Rachel has been focusing on with comparative effectiveness. Much of the view, I think, has been, though, that those comparative effectiveness studies or comparative effectiveness questions are harder to answer without either much more detailed data. And you heard Rich talk this morning about the more sophisticated propensity score matching methods that have been applied in Sentinel to do what he called comparative studies, but also randomized studies. And I wonder if you all have any thoughts about the next steps, and Rich did touch on these, of introducing more randomization capabilities or other approaches, maybe it's just richer data, to be able to move more in the direction of safety and effectiveness, not just safety.
Well, certainly, Mark, one thing I've always thought about in the context of doing clinical trials, one of the things we're always asked about is, well, how does this compare to patients that aren't being exposed to whatever the intervention may be that you're studying? So one of the things we've been wrestling with is how can you have a cohort of patients that are going through whatever that standard of care may be it for hepatitis C or for diabetes, not in a randomized trial, but being followed extemporaneously at the same time as a randomized controlled clinical trial, preferably in the same medical care settings. So you take some confounding factors out. Then you'd have a way to say, all right, what's the natural state of disease progression, of evolution, not so controlled as the randomized controlled trial. So you have a comparator group that could be very useful from both a regulatory perspective as well as a perspective of fleshing out the further promise of whatever therapy you may be studying. So that would be one. It's not really a randomized control within the context of a Sentinel-like database, but it is running in conjoint with a randomized control trial. It's an interesting potential approach.
Right, and Sentinel does have a history working with OMOP and OMOP successor activities of doing data comparisons to randomized studies and observational to develop more confidence in the observational methods. Marcus?
Yeah, we've been focusing a lot on pragmatic designs and trying to find ways that, and we actually have several we're undertaking now that within our environment where even to the point of randomizing them, and keep in mind as you randomize, especially in a real world setting, you also have to not only, because the individuals are receiving care during that process, and they also, ideally, when you're randomizing someone, you're randomizing them between, say in one case, looking at two different types of drugs. As you're doing that, you have to make sure your benefits are leveled at the same time. So you can't have, in other words, you can't have someone who's randomized to product A that has a copay of $5 and product B, which has a copay of $50, because now all of a sudden in the natural course of receiving the care, the one who's paying $50 is going to be less compliant with that, but most likely. So you have to, and that's a simple example, but there are a lot of considerations as we sort of deconfound them. Randomization does take care of some things, but it doesn't take care of everything in that case. So we're trying to really think through how we do this and how we can collect data as a natural course of care, more so, which lowers the burden on the provider and lowers the cost, and hopefully improves the speed of the data collection. But the pragmatic designs for us, which again include randomization, are going to be critical, I think, to accelerating evidence development, whether that's safety or effectiveness.
Thanks. Any other comments from the panel on this? Okay, Anna, please go ahead.
I think that when we are analyzing adverse events in such a huge database, we need to have also biological plausibility data. The example before with angioedema and ARBs and ACE inhibitors, they are both biologically plausible findings. One was positive, the second was negative. We need to understand why the results are not consistent. And I would recommend to use more comparators and to use biological plausibility data also. Positive controls, negative controls, and when something is not synchronized with the biological chemical structure data, etc., it needs to raise a red flag.
Thanks for the comment. Any further comments from the panel? Well, certainly important considerations, and heard from the panelists about the importance of using these data as well to have a better understanding of course of disease and things that could be compared to some of the biological data from other sources as well. Well, I want to thank our panel for an excellent discussion. In terms of next steps with Sentinel, we've heard a lot of further directions, including, as Dave was saying, fleshing out the descriptive statistics, the natural history available, natural history information available on diseases, on the use of treatments. We've heard about doing more today, not just in this session, but earlier, about doing further studies of safety that might be sponsored by other groups besides FDA, and using the Sentinel Initiative. Heard about that with IMEDS earlier, and the initial pilots of those kinds of extensions of Sentinel. We've heard about extending to not just evaluations about the safety of drugs, but about the impact of programs that are intended to affect the safe use of drugs, so-called REMS programs and other methods to limit or influence use of drugs to avoid unsafe outcomes, and really learning about whether those approaches are working or not. We've talked about using these kinds of descriptive data to help design trials, to answer questions that perhaps can't be answered using descriptive data, to design those trials as efficiently as possible, whether it's adaptive designs or otherwise. We've talked about extensions into the realm of comparative effectiveness research, risks and benefits together, which are a critical topic. We've talked about extensions into pharmacoeconomics, which is not just risks and benefits, but also costs or economic benefits. We've talked about use for quality, for identifying ways in which individual doctors and patients, or systems that are working to support doctors and patients, can best help them improve care. And we've talked about some more patient-focused extensions, including patient-level prediction, to being able to delineate subgroups of patients that may or may not respond to different treatments. And Ben's challenge to us to make this actually a resource that patients would find useful themselves, in terms of a way to pull together things that they might not know about themselves, not only to make sure it's right, but to help them take more steps in their own lives to improve their health, and to create more momentum for this whole approach. There are a lot of activities ongoing. You've seen Rachel did the overlapping map, Rich did the overlapping map this morning, and I think Chris could add to that with the various quality improvement initiatives, regional, local, and otherwise, that are also drawing on these same underlying data. I guess what strikes me the most is that we are, while we're still maybe a long way from a learning healthcare system, we're also a long way from where we were when the Sentinel Initiative began. Can you believe it? 7 years, for those of you who've been tracking it that long, began 7 years ago, in terms of being able to actually learn from all the data that are out there in the real world use of healthcare, to turn it into information and results that that patients can actually use, and that clinicians can use, and that can make our healthcare system better. So I want to give a thanks to all of our panelists today, but a special thanks to the panelists on this session, and all of you who contributed to the discussion about what the future, how we get from where we are to an even brighter future. That's what the Sentinel Initiative has really been about, and these meetings have really been about over the past 7 years. So thank you to all of you for joining me today. Thank you. And as I mentioned, that thanks extends to all of our other panelists, as well as to the FDA staff. This has really been a long journey for them, from the original vision to where we are today. Melissa Robb, Carlos Bell, Aaron Neiman helped us with putting this together, but the list of FDA staff who have been involved in conceiving and executing this initiative is much longer, and also should include Rachel Sherman, as Janet mentioned this morning. morning, although she's not still at the FDA. And then a final thanks to the staff at Brookings for their work on this overall effort and for getting this meeting together. Greg Daniel, Liz Richardson, Ahemsa Govinder, Matt Longo, Joanna, and I'm not out of time yet, right? And then finally, thanks to all of you. This is truly a collaborative, multi-stakeholder initiative. It only works because of not only your contributions to the Sentinel Initiative itself, but also your contributions and awareness and taking the information here back to help the work that Sentinel is doing extend to have an even bigger impact on healthcare and health outcomes for Americans. So thank you all very much for being here today, and we'll look forward to continuing to work with you in the next phases of the now no longer Mini-Sentinel Initiative. Thank you all very much.